Hello, I'm Dr. Ken Gilman, and today I want to talk about starting and adjusting the dose of tranylcypromine. Before I speak about that, I just want to say one or two words about other general factors which may affect the dose of parnate that's required in different patients. A lot of people think tranylcypromine parnate is only effective for atypical depression, but I think that's a self-fulfilling and incorrect view. If you get in the habit of using it for patients with biological, melancholic, endogenous depression, however you like to describe it, it doesn't matter whether people have got severe agitated melancholic depression or even psychotic depression with delusions of poverty and guilt and all that sort of thing. Tranylcypromine works extremely well in those patients. How it came to get the reputation of only working for atypical depression, I think, is an interesting story, but not one we're going to talk about this evening. But nevertheless, that affects dose. And in my experience, and I used to use it not infrequently as a first-line treatment for patients like I've just described, if you use it for those kinds of patients with typical endogenous depression, the dose range that's fully effective is, in my view, of treating at least 1,000 patients, around 30 to 50 milligrams a day. Now, occasionally, as with all drugs, you do seem to encounter patients who do require rather larger doses than that. And I've treated little old ladies with 120 milligrams, but that's extremely unusual. I would say that 90% of all the patients I treated got a good response in the dose range of 30 to 50 milligrams daily. Now, the reason I emphasize that is because in the large number of reports and inquiries I get through my website, I encounter patients who've been rushed, if you like, or progressed to fairly large doses of parnate pretty quickly, like well above 60 milligrams within a few weeks. And I think, except in special circumstances, that's often too much too soon. So that describes the background of what I'm talking about. Now, I'm not denying that difficult treatment-resistant atypical type cases may sometimes require higher doses, but let's deal with ordinary cases first, not just atypical cases. So how do you go about starting and adjusting the dose of parnate? Well, in my view, from treating a large number of patients, most fit adult patients can start with 20 milligrams. I don't think there's any need to start with a dose as low as 10 milligrams. But of course it depends on circumstances. And I do think that the pharmacological mantra, if you like, of start low, go slow, is extremely important, but not too low and not too slow. So there's a middle path with everything. And talking about good pharmacological practice and start low, go slow, the other thing I would emphasize is that it's extremely important not to change more than one drug at the same time. Often I get reports and inquiries about people who've had several different drugs changed all at the same time, and then something happens, they get more or less side effects, they get worse, whatever it is, and you don't really know why and what's going on. So it is a basic principle of good pharmacology to only change one drug at a time. My rule always used to be, you leave 5 half-lives for it to reach its new lower or higher equilibrium, and then you leave a decent amount of time, perhaps a week, to judge whether that's made any significant difference, for instance, in side effects or efficacy, whatever. Okay, so that's the general principles. Now, the other thing I really think is very important, and again, I base this on a very great number of patients that I've actually treated and measured their blood pressures myself in my office. Now, let me remind everyone about one of the aspects of the pharmacology of MAOIs, which seems to have been lost in history. There's a lot that's been lost in the 50 years of the history of these drugs. People who don't remember history are condemned to repeat it. Way back in the 1960s, MAOIs were used as antihypertensive drugs. They lower blood pressure. It's, in a vast majority of people, a therapeutic effect. And I have always maintained that it's good clinical practice to measure the sitting and standing blood pressure of all of the patients that you see. In fact, I used to do that once computers got into clinical practice. We computerized our private practice right at the beginning. I can remember having a dot matrix printer. And as soon as it became feasible, I wrote a relational database program to manage all my patient data. And one of the things I did was to record on the computer the data and have the computer plot a graph, a bar graph, showing how people's blood pressure changed with treatment. And I found that very, very useful because you could explain to patients what was going to happen and what you were going to do, and then you could show them how that came about and how it was really true by showing them the graph on the computer screen. So I measured the blood pressure of many hundreds of patients and plotted it regularly. I mean, I used to try and do it on every single visit, but of course, always every single visit. But almost all the patients I treated had a very thorough record of their blood pressure as it changed with the progression of treatment and changes of dosage. So what I say is based on an awful lot of good clinical data. Sadly, as a private practitioner having to earn a living and working hard, I never had time to publish that in a peer-reviewed journal. But publishing in peer-reviewed journals is a slightly overrated pastime in my view. But that aside, so what I'm saying is based on a lot of good data. If you measure people's blood pressure as you increase the dose, you see a very predictable pattern in a vast majority of patients. 95% of patients show this pattern. Obviously, there are always the exception. You occasionally see a patient who, no matter what dose of parnate you give them, they don't get a lowering of blood pressure. It's quite extraordinary. And on the other hand, of course, you see occasional patients who get quite a big drop in blood pressure on quite a small dose. And indeed, this business of drop in blood pressure and people feeling faint and falling over was really what made me get into the habit of measuring people's blood pressure regularly once I was in practice by myself. Because so often I used to see other doctors when I trained in London who tried to treat people with drugs like this. And the moment somebody said they felt a bit faint, they'd all panic and stop the treatment. Nobody ever actually measured their sitting and standing blood pressure. I used to find it quite extraordinary, absolutely extraordinary. Such a simple thing to do, and yet people didn't do it. Anyway, if you do it, this is what you'll find. With a small dose, you get an initial slight drop in blood pressure, and then very rapidly it comes back up again. Now, in a great majority of people, if you do sitting and standing blood pressure before medication in healthy people, the standing blood pressure will actually be slightly higher than the sitting blood pressure. Once the drug starts to get into the system, you'll get a very small drop initially and then it comes back up again. As you increase the dose a bit more, that second reading, did I say do 2 readings? I've forgotten. You do 2 readings. So you do it. It's actually better to get people to do it at home because then they can sit quietly for 5 minutes easily. When you do it in your office, it's not quite so easy to have people sitting quietly for 5 minutes before you do it, but that's the ideal, of course. And then you do one measurement immediately they stand up, and then another one immediately afterwards. And with these automatic blood pressure machines that everybody uses now, what that means is the actual reading for the second reading is going to be pretty much 60 seconds after they stand up. You can time it for yourself with the particular machine that you use, and you'll find that that's pretty close to being so. So if you use the same methodology all the time, you've got a standard. So once it really starts to get into the system, often with 30 milligrams, the second reading will be lower than the first reading on standing. And of course, if you increase the dose further, you'll get quite a big drop, and quite a lot of people will get at least some transient postural hypotension to the extension of feeling faint or dizzy. But I would add at this point that dizziness, the subjective complaint of dizziness and faintness, is actually a very unreliable indication of whether people have really got postural hypotension, which is another very important reason for actually measuring it rather than just trying to assess it clinically. Dubious. So the typical pattern that you see is shown in the graph that's attached to this, and that graph was produced by me from the average readings of a very large number of patients in my actual practice. Now, when you look at that graph, you have to appreciate one quite important point, and that is, let's take a hypothetical patient who gets a small but significant drop in blood pressure on 30 milligrams, which is relatively common. A lot of patients, perhaps 50%, something like that, will get a significant, consistent, persistent, measurable blood pressure drop of 10 to 15 millimeters of mercury on 30 milligrams. But if you leave the dose the same for 10 days and keep measuring it, that drop gradually gets less and less. Because, of course, it's probably to do with postsynaptic receptors and all of that sort of thing, becoming subsensitive and supersensitive and so on and so on. The system's full of feedback mechanisms which adjust over time and try to compensate for the interferences that we bring about with drugs. So you leave them on the same dose that produces a small blood pressure change for 10-14 days, and that almost always gets substantially less. It probably doesn't go away completely, although it does sometimes, but it certainly gets substantially less. And that's why I always say that it's extremely important to know the time interval between when you change the dose and when you're doing the blood pressure. And this is where the rather sparse amount of research that's been published about this in the psychiatric literature, and there really isn't very much. I've reviewed it. It's somewhere on the website. You can look if you wish, but it's hardly worth it. Excuse me. It's hardly worth it because there's so little data, and almost nobody has measured blood pressure twice after people stand up, and almost nobody reports the time relationship between when the dose was increased and when the blood pressure measurements have been made. So you just, you just can't interpret the data, end of story. So it's very, very important to know exactly how long they've been on what dose when you interpret the blood pressure results. Okay, so the reason for doing that is twofold. Firstly, because of course, with the variation in the sensitivity to different doses that different people exhibit, there'll be a proportion of people who do get a significant blood pressure drop on 20 milligrams daily and who get quite a big blood pressure drop on 30 milligrams daily. Well, obviously, if you've got somebody like that, that indicates the medication's having a big effect, and therefore it's logical to stay with that dose for a decent period of time till you can fully assess the result of that, and that might be 6 or 8 weeks. Obviously, how quickly you try to push the dosage up is going to depend on the patient's clinical state, their life situation, whether they're about to lose their job or get separated from their family and wife or whatever it is, all those practical consequences of illness have got to be taken into account in how urgent it is to increase the dose and get a response sooner rather than later. But that said, it's important just to assess it carefully and take it step by step. So if you've got a patient whose blood pressure is dropping a lot on 30 milligrams, you're likely to be patient and wait to see the full effect of the benefit of that, which might be 6 to 8 weeks. If, on the other hand, there's not a very big drop in blood pressure and people aren't showing much evidence of improvement, then of course you'll press ahead to 40 and 50 milligrams, using the same technique of assessing the blood pressure change and balancing that against clinical effects and everything else. So I think that gives you a good guide as to how to go about adjusting the dose. Because of what I said before, that in my opinion, in typical cases, 50 milligrams is almost always enough. If somebody wasn't getting much of a blood pressure drop, even on 40 or 50 milligrams, I would still wait a really decent period of time, I mean a couple of months, on 50 milligrams to get a really confident impression and opinion of whether it's made any improvement or not. If at the end of that time there's no substantial improvement, then that, I think, is always a time to reassess the diagnosis and the patient's life situation and whether you think they really do have a biological depression or not, and possibly even get a second opinion. But if those things aren't appropriate or necessary, or having done that, you still think that they need to continue with treatment, then obviously either augmentation or increasing the dose is the next thing to consider. But my view would be that once you get to 50, that's a sort of cut-off point at which you go to a sort of second stage assessment involving those things I've just mentioned. All right, I think that's all I'm going to say this evening about that process, because I think that's a good start. If you understand that, you're going to be able to manage and supervise most of your patients successfully. Thank you for listening, and I hope you found that useful. And I'll be doing 1 or 2 further talks on other aspects of treatment with tranylcypromine and the other drugs, talking about things like side effects and treatment of side effects and so on. But that's it for now. Thank you for listening.